Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Ladies and gentlemen, welcome to VITALS. VITALS is a forum for open and transparent discussion of how we can apply the VITALS tools, value, innovation, technology, advocacy, leadership, and service to create and promote change, and in doing so, solve the biggest problems we face in healthcare. It's an opportunity to learn from those who are leading from the tip of the spear now, implementing change to improve the quality of lives of our patients, and understand what they're doing and offer an opportunity to ask questions and learn as we all engage and move forward in the transformation of healthcare. Tonight, I'm excited to be able to introduce Dr. Cliff Megerian, who will be joining us to share what he is doing in healthcare transformation. Dr. Megerian is a true triple threat. He is a world expert in his clinical field in otolaryngology and has pioneered cutting-edge new operations to improve the lives of patients. He's an acclaimed and highly published researcher and a skilled administrator and leader. Dr. Megerian is the new CEO of University Hospitals, a top national academic health system. And tonight, we will hear how he is using the VITALS tools to transform healthcare at university hospitals. Dr. Megerian, the floor is yours.
I hope you can hear me, but thank you very much, Dr. Langell. I'm going to be sharing my screen here in a second, but let me just start. I think the notion of VITALS in terms of the notion of value, innovation, advocacy, service, all of that, as hopefully my presentation will show, are the necessary ingredients for any organization, whether it be large or small, that is in the healthcare business today. The pressures on healthcare and the changes that you outlined very nicely in your opening segment, that are the pressures and, if you will, the challenges that befall modern healthcare, are requiring organizations to think and rethink about their strategy, how it is they're going to continue to do what needs to be done in terms of delivering health, and how to, if you will, manage the changes with regards to cost pressures, the changes with regards to consumerism, the issues as it relates to delivering value, which obviously is the V in VITALS. And what I'm going to hypothesize to you today is that by carefully thinking through these things and building those into your operational plans and your strategy, that a healthcare system can thrive and in fact even get better during these periods, especially over the last few years and the coming years of significant increased pressures on healthcare systems. So let me grab my slides. I think I'll be able to, there we go. So what I'm going to talk about today, just briefly with you, and then we'll have time for Q&A, is the notion that strategic planning in academic medicine and medicine as a whole has to be very, very thoughtful as it relates to a number of pressures. First, I think it's important that the organization have a vision, and our vision is very clear, and it's been that for a long time. We are advancing the science of health, but with the art of compassion. Our mission statement, to heal and teach and discover, has been our guiding light for decades. And our values as it relate to excellence, diversity, integrity, compassion, and teamwork really are the core values that really drive our behaviors and then set our culture. But what I will say next is that to actually have a strategy that works today, we believe that you need to be thoughtful about the changes in academic medicine and any sort of organized medicine. And these are the following in our humble opinion. I think number one, the best healthcare still boils down to the individual doctor caregiver experience. And that has to be caring, filled with compassion, love, and high touch. I think second, healthcare organizations have to strive to be able to do that, but at the same time deliver value. And you know what value means. It is ultimately the quality divided by the unit cost. And we'll talk about how we're working very, very hard to do that. The next thing I believe is that you have to be very thoughtful about access and making sure that the value you deliver and the care you deliver is easy to be accessed by all segments of the population that you interact with, whether it be the inner city, whether it be the suburbs, whether it be rural or not. And that entire process be, if you will, bundled into a product that has at its very peak the notion of delivering the latest innovations and the latest discoveries, and actually that your organization is actually able to drive some of those discoveries so that your patients benefit right up front. So let me just talk a little bit about this organization. UH is an organization founded in 1866. It's a nonprofit entity. We have obviously our main campus, University Hospitals, Cleveland Medical Center. We have 12 wholly owned community medical centers, as well as 5 joint venture hospitals. We have over 40, now soon to be 50 major outpatient academic centers. We're an academic partner of Case Western, and soon we'll be welcoming students from NEOMED, which we're very, very proud of. We have close to 7,000 physicians and providers. Revenues soon will be close to $5 billion. And with the joint ventures, they are above $5 billion. And close to 123,000 discharges and close to 136,000 surgeries. How did we get there? I'm going to propose that the notion of holding out that the brand of healthcare that we deliver, that has carefully been curated to make sure that it has the best possible interactions between not only our patients and our doctors and nurses, but our doctors with other doctors of healthcare systems, with our system with other systems. In other words, collaboration, cooperation has led to what you see on this slide. And that is, before 2010, we were 9 hospitals. If you look at what's happening in the last decade, we've added a number of hospitals, including the potential addition of, well, this is a real addition, a joint venture with Western Reserve Hospital in Summit County. Now the addition of 3 fantastic Lake System hospitals, which will be joining us pending FTC approval. This now leaves us with 22 hospitals, now 50 outpatient medical centers, 30,000 caregivers, and we talked about the revenue. Why is this important? First of all, why is scale important? Scale is important, and your strategy should be based on getting scale, because the larger scale you have, the more opportunity you have to learn for what is becoming a major part of the healthcare of tomorrow, today, and that is population health. The larger populations you can learn how to find out how to, if you address their needs and keep them out of the hospital, the more successful you are in a healthcare system with the evolution of healthcare toward population health and accountable care organization. And more importantly, if with regards to a healthcare system's ability to do the highly technical quaternary care work, no one can argue that practice makes perfect. So you want scale so that you, with regards to your transplant program, for example, you have hundreds of transplants, not just a few. You need obviously at large scale to draw those patients. You have to have a strategic plan that incorporates some basic tenets. Ours is achieving excellence in quality and patient experience, inspiring a compassionate, engaged workforce. The higher compassion is infiltrated into the workforce, the better they are immunized against burnout, and more importantly, the better patient care they'll give. The better patient care that's given, the better outcomes. This allows you to increase market share and system revenue. It allows you to attract physicians. So I'll talk to you about how that's gone. It allows you to enhance your academic mission because you have more doctors and nurses who are able to pursue scholarly activity, and you build a culture of innovation and achieve strong financial positioning. So how have we done with regards to growth? This shows you that we've had 154% growth in the size of our operating revenue. Why that's important is that it allows us to drop margins, that being some if you will, profit at the end of the year that we can reinvest in doing better and better things. But scale helps get us there. Also, scale helps us have enough dollars to, if you will, divert from capital and new buildings and salaries to actually invest into research. So you'll see on this slide that UH's federal funding has increased, obviously, from 92 million to 106 million. If you add in our non-federal funding, we have close to 290 million in research in our partnership, either alone or with CASE. This allows us to have dollars that we can invest, if you will, in activities that are not necessarily driving a bottom line. And these are activities around our specifically committed to the academic mission. So that being education, faculty support, academic recruitment, distinctive programs. So this allows us to be having an increased cadre of residents. We have at any given time now over 1,000 residents and fellows with over 25 accredited programs. And we sponsor 86 different accredited programs. The 25 were non-ACGME. We've been able to bundle in and bring in the osteopathic residents into this platform, as well as podiatry, as well as actually dental residents. And what's interesting is that we draw our interns who then come to us from over 83 schools, and certainly NEOMED is slowly rising as a school that has become increasingly represented in our resident ranks. But remember, there's challenges facing academic medicine. There's headwinds facing academic medicine, and your strategy has to be able to allow you to overcome these. Clearly, number one, top line revenues are declining. Clinical revenue, what you get paid for what you do, will never be more tomorrow than it is today. So you have to build value, and you have to build other alternative streams of how to bring value to your hospital. The cost of conducting business continues to increase. The newest technology begets newer technology, begets newer technology. So it's very important that you understand that you have to be able to invest in doing business in the latest way. And at times, major breakthroughs become harder to come by. That's why you need scale. You need you need more shots on goal, if you will, for that your research projects deliver value and assets to patients and your system. And at times, there can be misalignment of clinical and research agendas. We work very hard to align those together. So talking about COVID and what are the new normal assumptions post-COVID, I think it's very important to realize that we will all use this post-COVID recovery to rationalize services. We may not be able to always have inpatient activity. We may have to move to telehealth. We may have to deliver more care at home because certain issues with regards to, certainly during the headwinds of COVID, didn't allow patients to be in the hospital. So we learned some amazing things. Sometimes the demand is going to be down because patients are afraid. Right now, 5 to 10% lower volume of patients. That creates problems. We're seeing patients sicker because they have diverted care and now they're coming in sicker. You have to develop ambulatory networks to shift to asset-light models. You have to be realistic that new primary care competitors will come into the market and you have to either work with them or compete against them. Healthcare as a whole is undergoing consolidation. We see it in our region, and you either are winning in that area or someone's doing it to you. And then the key thing that we always have to do is make sure that the patients who are in our system want to remain in the system for the entire part of their health care. What I want to show you just briefly is how COVID has helped us a little bit in providing a much more efficient value-based cost mechanism delivering ambulatory care. Before COVID, and if you see my slide here, you can see before January and February before COVID hit, we had a smidgen of telehealth visits. Now those have increased and reached a peak during April of 93,000 visits, if you will, per month. And now we're hovering and staying about 15% of our total volume is telehealth. That's a good thing. And patients are enjoying that. But we've also come to learn that some telehealth, it's not appropriate to be on video. You need to be in person so the doctor can examine you more closely. Health systems as a whole are facing a lot of challenges independent of COVID. Medicare is really forcing us to look at models of care that are population-based with potential rate cuts. Medicaid has in the past had rate reductions. We have a fabulous governor right now who's, I think, hopefully supporting the idea of not doing that again. We have commercial payers who are constantly challenging rates. We have new competitors coming in, growing consumerism. Patients want care now in the most efficient, easiest way. And we have consolidation. So what are we doing? We want to be a national leader in quality and patient experience. We've now become a national leader in population health. We are an absolute leader in the academic medical world of providing complex care, but also we are expanding to be a super regional system with increased scale so that other systems want to partner with us. We have to, if you will, be attractive to employers because employers see that we get their patients back to work quicker and keep them out of the hospital. One day we have to learn how to break even Medicare, and we have to continue our culture of innovation. These are some of the awards. I won't belabor them, but this is evidence that our strategy is working. 100 best hospitals by health grade, top hospitals in IBM Watson Health. Last year, we were the best employer in the state by Forbes. And we do these things. We're quiet about them. We don't often trumpet these things, but we use these as evidence of our ability to be able to, if you will, change with the times. One of the things that I'm passionate about is patient experience. And so I told you my theory is if you have engaged workers, you get better patient experience. We continue to have increases in how patients rate us. And in the ambulatory space, which is over hundreds of thousands of visits, 14,000 a day, we now, as of this year, have a rate your provider of 90% in thousands and thousands of our patients. When we started in 2018, we're down around 87. This is causing other doctors and patients to want to work with us. What's happened over time is we've had patients who join our accountable care organization, and now we're close to 600,000 patients. We're the 5th largest ACO in the United States. This is causing, as a result of that, more doctors who want to be attached to us so their patients can be part of a system. And although we have 2,700 employed doctors, we have 4,000 independent doctors who've joined our quality care network. The more patients you have, the more grateful patients you have, the more good work you do, the more support you get. And this is something that I think is incredible. this is philanthropy. This is what patients donate back to build programs that are important to them. And you can see our fundraising through at our 150th anniversary in 2016 reached 1.5 billion. In the last 4 or 5 years of our Quiet campaign, we've raised another close to 660 million. What that allows us to do is have discretionary dollars to invest in teaching, research, and programs. And last year during COVID, which is an amazing year, when we thought we were going to not be able to raise money, 173 million was given to UH to do things like build the Center for Women and Children's in Cleveland to deliver care directly to women who don't have good transportation or a good prenatal care. So again, we talked about scale, why scale and integration is important for health systems. It does increase contract leverage with health plans. It improves access to capital. You get better purchasing power with vendors. You get to at economies of scale with regards to corporate functions. You get to have better attributes and assets for physicians, so that grows. The better clinical expertise gives better clinical outcomes, and it spreads the risk over a larger population, which is our population health. How do we discover drugs? We created this fabulous program called Harrington Discovery. It was a $250 million initiative through the generosity of the Harrington family, who created a discovery institute with innovation support, which leads to drug development and sponsoring drug development based here in Cleveland, but all around the United States with brilliant researchers who are funded for seed money. And then if they have important discoveries with regards to drugs, then we help them license it and we help develop it here. And you could see all the folks, including the United Kingdom and Oxford, which is now partnering with HDI. This has allowed, if you will, 137 funded researchers from 58 institutions, and it's only been here 7 years. We've developed 28 funded companies, which brings jobs to Ohio, 11 clinical candidates out of those 28 funded candidates of drugs that now can help people, and 10 of those have been licensed to Pharma. And these are some of the partners with that work. So ultimately, and I'm going to stop here, we believe that the model for the future is in the middle, is a system that's willing to partner and be a collaborator with medical schools like NEOMED, with schools of engineering, with other health systems like we're doing, as you've read, with Western Reserve, and we're doing now with AltCare in Canton, business schools that help us learn how to be better business people, schools of public health. And this allows us to engage nationally better, create a multi-affiliate model, leverage our partners' expertise, develop a broad talent pool, and have not only local but global impact. And I'll just end with this. During the COVID vaccine, and Monica's heard this before, or maybe parts of it, I'm sorry, during the COVID crisis, University Hospitals was the first hospital in the nation to be asked by Gilead Pharmaceuticals to trial the drug remdesivir, who you all know received FDA approval for a therapeutic before vaccines were available. We were then the first hospital in the world to work with Masimo Corporation by virtue of these kind of platforms to develop the home monitoring system that keeps oxygen levels and through telehealth communicates with a central command center and allows people who are not sick enough with COVID to stay at home and be brought in if their oxygen levels drop. We then were the first hospital in the region to be asked by Pfizer to work on their clinical trial of their vaccine, which was approved. We also then were asked by AstraZeneca to work on their vaccine, which is going through approval, approved in the UK. And then most recently in the news 4 days ago, one of our most brilliant clinical trialists, Dr. Grace McCumsey, was told that she's going to be the first in the nation to be trialing an oral COVID therapeutic. So you don't have to have an IV. That is what happens when you do the things that we have lined up here. So with that, I'll finish up and certainly open for any questions and moderation by Monica Robbins.
Thank you, Dr. Megerian. Everyone, I know you have questions for Dr. Megerian, so if you would, please type them up in the Q&A section and I will be happy to ask them. We already have one question. You know, your predecessor's legacy of addressing healthy foods and tooth decay as a huge issue in lower income communities was awesome. If there's just one specific issue that you would have a positive impact on, what would it be?
It would be equal access to healthcare for everybody, so that by virtue of your zip code or by virtue of where you live or anything about you shall not in any way get in the way of you getting access to the best healthcare possible.
I'm glad you brought that up because that leads right into the social determinants of health that I know you are passionate about. How do you identify those and why are they so important, and how will you address that and attack it?
Well, we're doing it right now. I mean, I'll give you just a quick example, and we've doubled down on this most recently. We've learned social determinants of health that affect, let's say, the success of a childbirth. That those social determinants, for example, can be food and food scarcity or living in a food desert. They could be transportation and access to transportation, which keeps you away from prenatal visits. It could be help with regards to after your child is born, not having access to dentists, for example, as you mentioned. So we've doubled down in our Center for Women and Children's on 55th Street by doing a number of things, by building, if you will, grocery stores on that campus, stepping up even further, not only the food bank, but expanding the food bank to other parts of Cleveland to make sure that our patients have equal access to food to keep them healthy. And more importantly, by working with companies. So for example, working with Eaton Corporation most recently, I've been working with Craig Arnold, who's the CEO of Eaton, for providing PCs for people. We realize that some folks don't have access to a computer to do telehealth or to even check their own medical charts. So we have a fantastic program called PCs for People that we are working with Eaton to be delivering PCs and computers to these areas. And also with our partners at the Cleveland Clinic, we're making available our our buildings, which are many in Cleveland, to be housing towers for 5G and 4G networks to be delivered. So the idea is to make sure that the social determinants, such as access to food, access to transportation, that we ameliorate those things by delivering the care there. And if it means that they don't have access because of economies not allowing them to have computers, then we figure out how to deliver computers.
Stephen wants to know, talk about the importance of the physician clinician leadership in informing the success of strategic plans in healthcare.
Well, that's a great, this organization, and I'm a product of it. I never started out, to be honest with you all, with a goal to be a CEO of a company like this. My whole goal was to be an excellent, thoughtful, caring, and competent surgeon. But it was in 2008 that this hospital, which has been doing this for years, asked me to join a leadership training program, which was co-run at the time with the Weatherhead School of Business. And I learned a lot that I didn't learn in medical school about markets, about strategy, about competition over an 18-month period. And it was only then that I realized that I needed to know a lot more if I wanted to get more involved in helping set strategy for a 5 billion system. And I did that over the years before by a sequence of, if you will, of enhanced responsibility, whether it be a department chair in 2012, or whether it be the president of the physician organization in 2014. So it really took a deliberate, if you will, maturation of me, as well as dozens and dozens of other physician leaders that we now do on a yearly basis. And these physicians who want to, if you will, understand the issues surrounding the business of medicine are routinely, if you will, plucked to be joining and getting a seat at the table as we start outlining our strategic plans. And that's really built into the core of our culture, is internal promotion. Years ago, only 30% of our promotions to increasingly higher levels of responsibility were from internal people, whether it be physicians or non-physicians. Now that's close to 80%, Monica. That's because we have created a leadership program and a business training program to make sure our doctors, our nurses, our therapists are just as, if you will, competitive for a job or part of their job in leading the organization, designing strategy, as is a non-clinician.
I have a number of questions that lead into the same thing. So I'm going to start with this one. For patients, healthcare is local and they don't always understand consolidation of health systems that absorb their local hospitals. From a business standpoint, it allows the health system to benefit from scope and scale. And Michael Porter would state that it increases the power of the health system to decrease costs and advocate for patients. But how does a health system ensure that it is doing its best to balance the cost and quality savings with the local customer service that patients desire as part of the exceptional patient experience?
I think the fundamental thing that we do to make, you're absolutely right, Monica. There is a potential risk in consolidation, and if you will, the absorption of a community hospital into a larger network of hospitals. There is a risk, and it happens all the time, where that hospital joins and has a decrement in service delivery that is sustained and significant, and ultimately robs it substantially of tertiary and quaternary services. Overall, UH does exactly the opposite. That's our strategy. When we went into Portage didn't have sophisticated no backup catheterization. Our motto is to deliver that to Portage. They didn't have complex cancer care through Simon. We delivered that. And we similarly do that at every place, because it is our feeling that by delivering care that can be delivered local is better delivered local. People are happier and safer local. And we found that to be the winning strategy. And I will argue perhaps that now the market has recognized that. And why do I say that? The most recent, if you will, news, the Western Reserve decision and the Lake decision were not our decision. They were community hospitals making a decision on who to join. And one of the reasons I suspect they joined us was because we have that history of doing that. When we were fortunate enough to get Geauga, we were fortunate enough to get Samaritan, we increased the CMI. We increase the portfolio overall. I mean, sometimes we have to reshuffle between hospitals that are close to each other, but in the end of the day, we increase the activities, we increase the delivery of physicians because we believe that that's the safest, best, low-cost way to deliver healthcare. And it's showing in our Medicare shared savings data. The MSSP data is now showing that we've actually dropped costs from 2018 to 2019 by 6%. We're actually the lowest cost per member per year of a Medicare patient in the state of Ohio. We actually increased our quality to 97.4. And so if you look at our value play, which is a big part of VITALS, that strategy is actually delivering results for our patients and our communities.
Beth wants to know, though, when is big too big?
I think big is too big when you if you lose the high touch care, the 5-star care, and the ability for the leaders of the organization to be able to intervene and spread the culture. Culture trumps strategy for lunch, as they say. And if you get too big, now too big for one person, maybe 100 hospitals, too big for other people, maybe 3, right? And if you become too big, and that is a variable term, you know it because you're going to have a decrease in value, you're going to have a decrease in patient experience, a decrease in quality, and unhappy people. So I think there's not an absolute number. It's based how you manage your culture.
Kathy wants to know, how do we win over a population that is distrustful of physicians?
Well, I think that's an area that we have. I mean, there's certain segments of our population, and I'll boil it down to what we're dealing with just today. I mean, we have segments of our population who are distrustful of the vaccine, and these are our patients. So how do we address that? First, we try our hardest to hire doctors who look and are make those patients of that particular segment, whatever segment it is, feel comfortable because they see and they meet and they feel a provider who is similar to them ethnically, racially, some demographic. And we educate and we talk and we listen. And by virtue of doing that, for example, with parts of the African-American population that we're worried about, and rightly so, for the vaccine because of the history of experimentation, especially the Tuskegee Institute experiments starting in the 30s, you have to listen and understand and acknowledge the concern. Then you have to be able to present, if you will, caregivers who can help ameliorate the concerns by talking through it. And it takes time, it takes effort. You're not going to be able to reach everybody, but you have to try.
Stephen says, you spoke about the importance of compassion in healthcare delivery as a key value at UH. My care providers mostly interact with their computers, who occasionally look in my direction for clarity of information. With all due respect to the importance of electronic health records, how do you balance the experience of patient encounters to create a compassionate experience?
You know, the Act of 2010 that required all hospitals in the United States to use the EMR by some measures was a good thing because it standardized the collection of healthcare information. But by many measures, it was a bad thing because it increased the workload on physicians and it created the environment that the last questioner pointed out very appropriately, that some physicians get distracted by their computer and lose the intimate patient-doctor relationship. So how do you combat that? First, you have to first look at the platform that you're using. And at UH, we've come to the conclusion that the platform that we're using is not allowing enough flexibility to our providers to be able to have eye-to-eye contact in all circumstances with their patients. So we're moving away from it to a brand new one. That will allow much more ability for voice recognition, templated work that allows for better. We've done things to try to mitigate that by bringing in scribes and hundreds of scribes to be able to partner with physicians so their physician can look where they should be at the patient. I still see patients. And the way I deal with it is I have an EMR, but I stay later at night because I talk to the patient and I'm fortunate enough to remember what happened. I go back at night, put everything in. But that's hard when you're full-time seeing patients. So what we are doing at UH is developing a strategy to decant the best we can that handicap of people's eyes not being on their patients and being on the computer. But we got work to do, as does the nation.
We're getting a lot of great questions here, so I want to thank all of our participants who are checking in. Also want to encourage you that if you do have questions for Dr. Megerian, please put them in the Q&A section and I'll get to them. Vaughn says, we discovered a drug for heart failure treatment, microvascular. They've done all preclinical studies and now need to move to clinical trial. He wants to know, is it possible to collaborate with UH and do clinical trials?
Well, we have actually the most clinical trials of any hospital right now, active clinical trials in the state. I would urge that person to communicate with either myself or Dan Simon, our head of the main campus, and put him in touch with our cardiovascular team at the Heart and Vascular Institute.
I can also say I just interviewed Dr. McComsey recently, and you also have a page on UH for those who are interested in getting involved or sharing clinical information. And just to give props where props are due, you have over 200 clinical trials going on right now at UH, and those are just those involving COVID alone.
You're absolutely correct. That we have thousands of clinical trials in the heart and vascular space and the cancer space. And as I mentioned Grace's name earlier, she was the one who landed this very, very important clinical trial with an oral. But I would suggest to the Vaughn, I think was the person who asked the question, I think it was Vaughn, about the heart drug, is to reach out to Grace McComsey and we will analyze it.
You touched on the pandemic and the impact on hospital care. I'm curious to know, from healthcare costs, the negative and positive impact, you touched on it, but in the long run, in the next 5-10 years, where are you going to see this pandemic, the impact it's going to have long term?
Well, we're still in it, and there's no doubt about that. I think that in terms of the costs, I want to think of this as a potential silver lining situation. I think there's a very good possibility that as we get herd immunity, which we think we'll get by October, November, as COVID moves from being something in our forebrain to the back of our heads, which I think it will when we get enough vaccines, enough therapeutics, and but it will no longer be, if you will, the daily threat that it is. But I think we could learn things we learned during COVID to help lower the cost of care. So we've learned that we can deliver very effective care in certain circumstances by telemedicine. We've learned that we can do operations that we thought we could only do as an inpatient safely as an outpatient, hence lower costs. We know that there's a lot of redundancies that we've detected by virtue of building systems to manage COVID data that we found were clunky, and we have to fix those. We'll be more efficient. So I believe that we will be ultimately learning from this event the many things that I've talked about, silver linings to help us lower the cost of medicine. But I don't want to be Pollyannish, Monica. The cost of medicine continues to rise. I mean, we are the only nation where the healthcare costs are close to 20% of our nation's gross domestic product. The closest in the G8 is close to 8 to 11%. So we've got some work to do. And I think it is working around really two major areas. Number one, as deliverers of healthcare, understanding how to get rid of waste in healthcare. There is clear evidence that nearly 30% of our spend is on things that don't need to be done. And that is part of the notion of value-based care. We focus on that every day. It's called high reliability medicine. We also know that there's mistakes and injuries that happen. And you know that, we all know that. And by creating the best system we can to prevent defects in the system, or if you will, problems with care delivery, because a readmission, for example, or a complication, an infection after surgery, is very, very expensive to everyone. And so we are working very, very hard to push those down and lower those down in terms of our overall work that we do.
You're at the beginning of what will be a legacy for your tenure here as the CEO of UH. Mission number one, and what do you hope to leave after your legacy is over in the next, I'm going to say 20, 25 years?
Yeah, well, thank you for that vote of confidence. You know, mission number one for us, and I will say for us, is for UH to continue, but more importantly, to become branded in the eyes of our community. And when I say our community, I mean our patients, I mean our employers, I mean our payers of healthcare, that being the insurance companies, I mean our municipalities, and I mean our friends, and friends meaning other hospital systems, as the most trusted platform and provider of healthcare by virtue of being able to deliver what I laid out at the beginning of this talk. That is 5-star care, whether you're on the phone, whether you're in person, or whether you're dropping off your car at the valet, that individual experience is a 5-star experience, coupled with the value that is measurable, that we now measure and is measured for us, coupled with the accessibility, and we become the consumer choice because you can get in to see us digitally by many channels, easier than anybody else, to the doctor that you want or the nurse that you want. Then coupled with the science that's built around it, the work that Grace McCumsey's done, the work that Dr. Slaughter is doing, as being able to deliver, God forbid you have the most bizarre, rarest problem, this is the place that you should be. That concept of that brand will become solidified, and we will deserve that reputation. So we're working very hard toward that.
Stephen has a very interesting question. As a key healthcare leader, what keeps you awake at night?
Well, you know, healthcare is an unbelievable business, and let me just give a brief answer. You know, just a few short years ago, the CEOs of 3 of the largest companies in our nation, Jamie Dimon from JP Morgan, Warren Buffett from Berkshire Hathaway, and Jeff Bezos from Amazon, really felt that because of they've been so successful in their businesses, they could fix healthcare. They're brilliant men, fabulous, but in different businesses. And they created a company called Haven, and they were pretty much on track. They wanted to fix healthcare. After 2 years, they just announced they quit. They can't do it. And they don't want to even be involved in the healthcare business. They got rid of their CEO. It was a brilliant guy named Atul Gawande. Okay, why did that happen? It happens because healthcare, number one, it is a tough business and the rules change every day. So the question was, what keeps me up at night? It's what I don't know. Because I feel pretty good that the team that we have gathered is already got a plan for what we know, whether it be changes in legislation, whether it be changes in the disease process, whether it be changes in regulation. But what is it that's going to happen tomorrow morning? Because the rules can change any day, whether it be state, federal, city, or payer. And so I think those are the things that keep you up. But at the end of the day, Monica, you know, you're not going to be successful if you're up every night worrying about something. So I have developed such a trust for the people I work with and the team of professionals that we have, so that when it is time to go to bed, I'm pretty much able to go to sleep.
I'm glad you brought up what you don't know. You know, we have a new administration in Washington right now, and there's talk that there are going to be changes made again to the ACA. What are you anticipating will happen, and what are you hoping, and what are you not hoping for?
Well, I think President Biden is very committed to the Affordable Care Act. I think that he sees that as part of his legacy, is to strengthen that in the years to come. So the principal fear I had before the election of a administration wanting to somehow tear out the ACA was very, very distressing to me and most of my colleagues. Why? Because at the very least, the Affordable Care Act has allowed for Medicaid expansion. Again, our governor has been fantastic in allowing that in a Republican state. It has allowed for children to stay on their parents' insurance till they're 26, and it allows for it be illegal for insurance companies to not allow a person to have insurance by a pre-existing condition. I think there's a chance that President Biden and his team, I mean, we're waiting to see who gets appointed for the head of Health and Human Services. I think there's a hearing right now for Javier Becerra, the former Attorney General of the state of California. It would be up to him, but I think there's a chance that President Biden may want to loosen entry into Medicare by virtue of age. Right now at 65. He could, based on his campaign, want to allow earlier entry into Medicare. That would be a game changer for our business, right? Because it's a different payer mix, a different payer strategy, but we would have to learn to deal with that. We would have to learn to adapt. That's the thing about healthcare. You have to adapt really, really quickly. So we are following, I'm following of an amazing government relations team led by Heidi Gartland, and we literally meet on a regular basis, not only to talk to our senators, to talk to the people at HHS, to learn what is in store for us, and if needed, lobby. And we are not shy about doing that.
That brings up Kathy's question. Does UH continue to advocate for clinical trials and pharma protocols before Congress?
Oh, absolutely. You know, we've been before Congress many times. I mean, not in the last year, but we've been before Congress. I mean, clinical trial work is exceedingly important. I mean, most of it is sponsored by a pharmaceutical company, and they look for the best partners who can deliver rapid results and safely enroll patients. And we believe our platform and the way we've been able to do it, led by Dr. McComsey, is very, very suited to be probably one of the top performers in the nation.
One of the things that just happened at the first of the year was the healthcare cost transparency law that went into effect that a lot of hospital systems were opposed to. You know, that's only going to grow. How has that impacted, you know, from your perspective, how will that impact hospitals and the way they're billing, and compared to what a patient may pay, compared to what the negotiated rate with the insurance company will be?
Yeah, I'm not entirely sure yet, because it is still a little bit difficult to read through the regs. There's hundreds of pages of regs, and it was moved very quickly for January 1st. We have, the first job was to have machine readable data on your costs, and then have your negotiated prices for 300 different common procedures. I think that will allow, if it's done well, patients to get an idea, but I don't think it gets them the true idea of what their bill may be. I think we've been working hard well before this to have what's called clear quote, which we would have for 8 years, where someone would be able to know, based on their insurance, based on their copay, what exactly their out-of-pocket would be. So I don't know exactly the value of knowing the individual negotiated price at a particular hospital for a particular service and how a patient is going to. I think it'll be great cannon fodder for newspapers and researchers to do their analysis, but I don't know exactly how that in alone is going to help. I think what really helps a patient is to be able to get an idea of what the episode of care, maybe not what the knee surgery is that day, but what is the whole 90-day episode of care and the cost for them. And I fully support that.
You talked a lot about collaboration, obviously with the systems that are being incorporated into university hospitals, but also with your competition. Can you talk about how that collaboration has truly blossomed and what impact it's going to have, at least here in Northeast Ohio?
Yeah, I think we did a podcast, Tom Mihalovic and myself did a podcast with advisory board on how this all happened. We went out to dinner before COVID hit, and we both looked at each other and we said, we need to compete to give better care for our patients. The more we compete, the better outcomes each of us will have, and even each of us will force each other to be better. But there's many things that we do together that frankly we don't compete about. We don't compete on laundry. We don't compete on central sterile supply. We don't compete on buying food and lettuce for our groceries. We don't compete on needing to be able to provide jobs and entry-level jobs and job training for high school students. So why don't we put together 6 pillars whereby we will collaborate? Included in that was response to the opioid crisis and then response to COVID was Leo did when it happened. So we're meeting next week, 15 of them, 15 of us. We meet every 2 months. Me and Tom Mihalovic oversee it. And we now are having discrete outcomes on each of these areas of collaboration. One of them was how we collaborated in, I think, a very successful application to Jobs Ohio for grant dollars to build research programs to encourage job creation. As you know, that was announced by the governor a few weeks ago. These are examples of a spirit of collaboration. You know, we opened up a joint testing center at the Walker Building when COVID was first out. We together helped the city of Cleveland deliver vaccines when they needed help from a hospital. We did it together. These are the kind of things that we should be collaborating with. And from what I understand, this actually is becoming a national model because people just don't do that.
Richard wants to know, you mentioned the need to reduce costs, and you also talked about being able to successfully deliver Medicare services at Medicare rates. So what is UH doing to be able to lower costs and thrive on those lower Medicare rates?
Number one, the answer typically comes from being able to have an understanding of not just one patient, but a population of patients, understanding how to keep those patients out of the hospital. Usually to lower the rate of the care of a patient, it's typically escalated by the inability to prevent an exacerbation of a chronic illness. So if you could design a primary care institute like we have, I'm not saying we're there yet, that you have by virtue of electronics, artificial intelligence, and understanding of, let's say, the diabetic patient who hasn't been in to get their hemoglobin A1C checked, and you know statistically that means it's probably going the wrong direction, you have a way to touch base with that patient to encourage them to make sure they're taking their shots or taking their oral hypoglycemic, and that patient then is prevented from going to the hospital in diabetic ketoacidosis or with a complication of diabetes. So the key is to manage the chronic diseases within your population. The second, Monica, is to deliver high reliability medicine. You stop doing things that don't bring value to that particular type of care, and then you minimize the defects in the system. Those are the 3 things that we do that has allowed us to get down to the level that we are in terms of our per cost per member per year for a Medicare patient. And then you figure out other ways of reducing costs in your overhead. So getting economies of scale, thinking of new ways to, if you will, deliver things that you need to have, the table stakes. So those are the basic mechanisms of doing it.
We have another question. What's one of your favorite things as CEO of UH, and what gets you out of bed in the morning?
Well, usually one of my dogs gets me out of bed in the morning, either Henry or Steve. But I think my favorite thing about UH, and I think it's the reason that I came back from Boston in 2002, is the friendliness and the collegiality of the folks who work here. It is a family environment. We treat each other like family. We care about each other. Certainly there's hierarchy, but not so much that's palpable. It is a very, very collegial environment, I think, and it's committed to its founding of, the most worthy is the most needy. And I think that's very, very important.
as you're, I'm going to give you a second or two to combine some final thoughts and throw out any more questions. Please put them in the Q&A section. And while I'm doing that, anything else you want to round out your discussion about?
Well, I mean, it is my guess, although I don't see the audience, that many of the audience may be medical students and NEOMED students. I think it's very, very important. This may seem distant to them. This may seem like something that they don't have to study for because it's not in the biochem exam. I would really urge the medical students to begin thinking about what, as it relates to the ideal healthcare system in the United States, that they are drawn to, and educate themselves about those things. It may be that they're interested in being a primary care. If they are, they should be really looking into how population health works and the theories of population health. Whatever it is, try to augment your curriculum. And I'm sure Dr. Langell already has a fabulous curriculum that has leadership and other things, but do some of your own reading and self-teaching in areas that are of interest to you. That will help you a great deal in your career.
When you were going through medical school and your fellowship at Harvard, did you ever think that one day you were going to be leading a hospital system as large as this one?
No, not at all. No, I never even dreamed of it. It wasn't in my windshield. My windshield was, as I said, to be the best surgeon. And then once I became a surgeon, I ultimately wanted to lead a department and be a department chair at a medical school in a large academic medical center. And then, even then, I didn't think about being CEO. It was only after, Monica, that I was asked to run the physician organization, which was that conglomeration of 2,700 physicians. And I started really learning a business that I said, you know, if they ever ask me, it's something I may be able to do. And that's the only time it started coming to me, is during that time. But again, this is still a blessing and something that I never planned. But I was prepared because I had the training, the education, and the bottom line is, I think, ask questions. I asked a lot of questions. I had probably too many questions and probably annoys people, but ask questions.
Dr. Megerian, thank you so much for your insight. Dr. Langell, I'll hand it over to you.
Well, thank you, Monica. And Monica, thank you again for your dedicated leadership and expert moderation for the VITALS program. Dr. Megerian, on behalf of all of our participants today, thank you for sharing your comprehensive leadership approach to healthcare transformation at university hospitals, especially your steadfast focus on the patient experience, social determinants of health, patient outcomes based on quality, and being able to control costs for the benefit of our patients, because it really is all about the patient. And you're doing so while still investing in research to better healthcare for the future. So thank you again.
Thank you, Dr. Langell. And again, thank you, Monica. You did a great job.
Ladies and gentlemen, please join us next month when we'll welcome Dr. Hal Paz, the Executive Vice President and Chancellor for Health Affairs at The Ohio State University, to share his vision and his use of VITALS for transforming healthcare at that institution. Until then, stay active and engaged. You are the change agents who will help us to transform healthcare for that sake of our patients. Have a good night.
Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary health leadership in action.